Hello students, welcome. Myself Dr. Roshni, your OGY faculty at DigiNerve. So since we are doing our last minute pearls for our NICT, the round the corner exam, so the second most important topic from obstetrics would be your postpartum hemorrhage. Yes, this is a must know topic. Without this, you cannot go to the exam, isn't it? So let us do a quick revision of this. Yes, by definition, postpartum hemorrhage is any amount of bleeding from or into the genital tract that is causing deterioration to the patient. Maybe her pulse rate is raising, her BP is falling, or she is going to shock whenever it is deteriorating. In quantitative matter, following a vaginal delivery 500, following a cesarean section 1000, following cesarean hysterectomy 1500. So what is primary PPH? When it is within 24 hours of delivery, then it is primary. When it is after 24 hours, then it is called as secondary PPH. What is minor? When the blood loss is less than 1 liter. In major, there are two categories, moderate and massive. Moderate is 1 to 2 liters, whereas more than 2 liters is a massive blood loss, that is massive PPH. Okay, this is the basic definition that you should know. I know you all know this. Let us move ahead with the prevention. So what is it? This is also one of the commonly asked or must know topic, both for your theory, practical, MCQ, whatever it is. AMTSL is a must know topic. What is AMTSL? Active management of third stage of labor. Okay, so what happens in active management of third stage of labor? Firstly, you will give injection oxytocin, 10 units. Either you give IV or IM. IV is a slow infusion, or never give IV bolus. Never IV bolus is given for a case of oxytocin. Okay, or IM 10 units. This is the best and easy route, especially in PHCs. For the sisters that you can tell, IM 10 units of oxytocin. Next would be delayed cord clamping. The baby in the placental cord clamping should not be done immediately. There will be enough blood that will go to the fetus instead of just pouring out after the placental expulsion. So delayed cord clamping will also prevent your postpartum hemorrhage. Lastly, it would be your controlled cord traction. So never pull the placenta, or it will get snapped and then it will be a manual placental removal. So always do a controlled cord traction. So these are the three basic steps that if you follow these things, then almost 80% of PPH can be prevented. Okay, by just following these three steps. Initially, delayed cord clamping was not there. This is a recently added one. Initially, it was uterine massage. So it was more causing a patient discomfort than giving prevention of postpartum hemorrhage. So that is discarded now, and delayed cord clamping is being added. But remember, uterine massage can be used for PPH. If a patient is having PPH, then you do uterine massage. There is no doubt about that. But for prevention of PPH, you don't have to do uterine massage. Understood? So these are the three basic steps of active management of third stage of labor. Okay, next, going ahead with the common causes of your postpartum hemorrhage, the 4T's. The 4T's: trauma, tone. The most commonest one is tone. Tone of the uterus. Atonic uterus almost causes 80% of the cause for postpartum hemorrhage. Then will be your trauma, your cervical tear, deep episiotomy, angle extension, inverted T incision, whatever it is. All the trauma and laceration comes for the T. That accounts for almost 10 to 15% chance of postpartum hemorrhage. And third one would be your tissue, that is your retained placenta. Remember, retained placenta is one of the commonest cause for secondary PPH. Whenever the patient presents after 3-4 days saying I am having severe bleeding, always think in terms of a retained placenta. This is the commonest cause for secondary PPH. Okay, secondary PPH, then you should think in terms of retained placenta. Thrombin, like coagulopathy deficiency, DIC, all these things are the last or least cause, 1 to 2%. Especially in our preeclampsia, where they already have thrombocytopenia, again they will bleed. Preeclampsia itself will have high chance of PPH. Now because of low platelets, again they will bleed a lot. Okay, in such cases you should be very careful. Next, coming to prevention, there are three methods for prevention. Treatment of postpartum hemorrhage. Medical method, which we are going to tell now. Then comes your mechanical method. Then is your surgical method. So in medical method, the common drug is oxytocin. As we told, it is used in prevention also, and it is used in treatment also. The dose is 10 to 20 units can be given. You can give either IV or IM. Both routes can be given. And you can give continuation, infusion pump. At 10 units you put, and at the rate of 20 to 40 drops drops per minute. Maximum of 60 international units only can be given, not more than that. Contraindication is it is contraindicated as IV bolus. Never give as bolus. Okay, oxytocin is never given as bolus. Then comes your methyl ergometrin, the magic drug, almost prevents all BPH. Okay, so this is one of the magic drug which contracts both upper segment and the lower segment, and this can also be given both IV and IM, but we prefer in case of severe PPH IV route, faster action, faster reduction of blood loss. It is given at 2.2 mg. Okay, and after 15 minutes you will recheck. If it is still bleeding, you can give up to 5 doses more. 5.2 after 15 minutes, another 1.2 mg, after 15 minutes another 0.2 mg, like that you can give maximum up to 1 milligram, 1 gram. Okay, 0.2, 0.2, 0.2, like that you can add. Only up to 1 gram can be given. Then is your contraindication most important for your methyl ergometrin or methergine. That is your preeclampsia. Hypertension in pregnancy has highest chance for bleeding, and for them only you cannot give this drug. Okay, so hypertension in pregnancy you cannot give, cardiac disease you cannot give this drug. Okay, because it will cause vasospasm and increase hypertension, and even it can cause cerebral palsy and things like that. Okay, that is why you should not give in cases of hypertension in pregnancy and even in cardiac diseases also. Thirdly, coming to your carboprost, your prostaglandin F2 alpha. Remember, this is the only drug, the route is only IM. You should not give IV. Contraindicated as IV. Okay, and the dose is 250 micrograms. Okay, so 250 micrograms can be given, 4 doses every 15-20 minutes. You'll recheck and you can give, that is your 1 milligram. Okay, you cannot give more than that. Contraindicated in asthma patients. Okay, as it causes bronchospasm, it is contraindicated in asthma patient. Also it is contraindicated as IV. Okay, you should not give IV. And fourth one is your misoprostol, prostaglandin E1. That is per rectal oral route that you can give. Oral or per rectal route you can give, since you'll be bleeding, no point in giving PV. So per rectal route you can give 400, 600, 800, like that. Maximum up to 1600 micrograms you can give it, milligrams you can give in 1 day. Okay, tranexamic acid is again IV, slow infusion. You can give infusion, that is 1 to 2 grams, and total of in a day you can give up to 3 to 4 grams. Okay, this is about your tranexamic acid. And remember, in coagulopathies or convulsion disorders where chances of having thrombosis is more, try and avoid tranexamic acid. It should not be given. This is about your medical method. Then comes your mechanical method. So in mechanical methods, that is manual compression. One is uterine massage that we told you. You can do uterine massage. And next, what is this? Since they've asked many image based question, I've put this. What is this? This is bimanual compression. Okay, bimanual compression. So what happens in this bimanual compression? You are compressing the vessels. One hand is from the vagina and one hand is from the upper abdomen. You will compress the anterior and posterior uterine wall as shown in the figure. That will prevent from bleeding. What is this? This is your Bakri balloon. Okay, this also in the same way, you will put the Bakri balloon inside and inflate it with 200 to 500 ml of normal saline. Here again, as you can see in the photo, it will coagulate the vessels. Okay, it will block the vessels or cause the pressure, just like how you cut and you pressurize and keep, the same way it will pressurize on the venous sinuses and it will help in coagulation of the blood. Okay, so this is how you can either use condom catheter, Foley's catheter, or Bakri balloons, Engstein balloon. All these things can be used for your mechanical methods. So these are the mechanical methods. Lastly, coming to the surgical methods. So surgical, especially in case of placenta previa or PPH, you are suspecting polyhydramnios, over distended uterus is there, you are suspecting PPH. In such case, you can do, or if there is bleeding, you can do B-Lynch sutures. Okay, B-Lynch when you have opened the uterus, and Hayman's when your uterus is not open, that is following a vaginal delivery, she is having severe PPH. Okay, and one more would be your Cho square stitch, that is for your placental bed suturing in case of placenta previa. Okay, this is your surgical method. So if they give you this photo where you can see anteriorly we take, go posteriorly and come back from posterior, and again from posterior to anterior we come and suture in the anterior part. This is your B-Lynch sutures. Okay. Lastly, if none of them is working, then we will go for stepwise devascularization. This is also these days commonly asked question. So where do you in stepwise devascularization, which artery is first ligated? It is your uterine artery. First, you ligate your uterine artery, then is your uterine ovarian anastomosis at the cornea, 1 centimeters below and lateral to the cornea. You will ligate, that is your uterine ovarian anastomosis. If still it is not controlled, then you will go for internal iliac, anterior branch of internal iliac artery ligation. That is where your common iliac artery will bifurcate, no, anterior and posterior, or internal and external. So at the bifurcation, from the bifurcation, you'll come 3 centimeters below. Okay, 3 centimeters below, and you will ligate. Why 3 centimeters below? Because you do not want to include your posterior branch. Only anterior branch has to be coagulated, ligated. Otherwise, if you include posterior branch, they are end arteries. They may develop gluteal region abscess and all. So you should not include your posterior branch. Only the anterior branch has to be ligated. So remember, the third artery is your internal iliac artery, and that is why it is 3 centimeters below your bifurcation of and internal and external iliac artery of common iliac artery. If none of them is working out, then you can end up doing a cesarean hysterectomy, or you can even do uterine artery embolization. For example, a case of placenta previa is there. Very well, you know she will bleed a lot. You can put the balloon and keep. If she is bleeding, you can embolize the artery. Uterine artery embolization also can be done. Okay. Polyvinyl alcohol is the particle used in uterine artery embolization. This ends your PPH topic per se. Let us end with some of the MCQs. Which among the following is the risk factors for developing PPH? Severe preeclampsia, yes. Retained placenta, yes. Obesity, yes. All of the above, yes. So the correct answer would be all of the above. Then the next question is, a 28-year-old Gravida 3 para 2 female delivered a normal child followed by delivery of placenta in toto. In toto means that has come out in total, where there was a torrential PV bleeding after 3 days. So this is a case of secondary PPH. An urgent sonography revealed retained placental tissue. What is the suspected condition? So it is a retained placenta. As we know, secondary PPH commonest causes retained placenta. So what is it? Placental abnormality. The one placenta that you knew came out, but then the another lobe, attached lobe, would have not come. This is called as succinsurate lobe of placenta. Yes. So this is the correct answer. In placenta accreta, increta, percreta, this is your placental adherence syndrome. Here what will happen? Your first placenta that came in toto only would have not come. It would have been adherent to the placenta and it would have been there only. Initially only you would have find it difficult to remove the placenta. Okay. So this will not be the answer since the first placenta came out in total. Okay. So the correct answer is your succinsurate lobe. Next question, carbopros, that is your prostaglandin alpha, F2 alpha, is used in medical management of PPH. Which among the following is not associated side effect? Bronchospasm. Yes, it will cause bronchospasm. That is why we do not give an asthma, isn't it? Constipation. No, it doesn't cause constipation. Yes, it will cause some amount of vascular spasm leading to hypertension. And lastly, fever. All prostaglandins has some amount of fever with it. Okay, so the correct answer will be constipation. Next question. Which among the following is not a management option for massive PPH? If somebody is having massive PPH, which is not used? Balloon tamponade, yes, it is used. Hysterectomy, final option, yes. Thermal endometrial ablation, no, this is not used. This is used in AUB case or gynec patients. Any endometrial thermal ablations is not done in obstetric cases, remember. Okay, B-Lynch, yes, it is used. So correct answer will be C. Next question. Which among the following is true regarding various obstetric shock index used in diagnosis of PPH? So what is shock index? It is pulse rate divided by systolic blood pressure. Normal range is 0.7 to 0.9. Okay, so this is the normal range. But remember, anything more than 1 is suggestive of PPH. Normal value of obstetric shock index is more than 1. No, this is wrong. During pregnancy, if the value range is 0.7 to 0.8, then it is reflective of massive bleeding and requires blood transfusion. No, 0.7 to 0.8 is a normal value. So this is also wrong answer. A value of obstetric shock index more than 1, a patient is in PPH. Yes, this is how you diagnose a case of PPH with obstetric shock index. None of the above. No, the correct answer will be C.